Welcome to Cutting Edge Pain Relief, and today I have with me one of the most distinguished regenerative medicine specialists in the United States and probably outside the United States too. His name is Dr. Christopher Williams. I've had the pleasure to be able to meet him, know, and learn from him. Phenomenal physician who's going to talk to us today about non-surgical knee treatments, specifically subchondroplasty, and used in the context of regenerative medicine, which he's going to explain exactly what those details happen to be. But just a quick background on Dr. Christopher Williams. He's a gentleman who's originally from Jacksonville, Florida, who actually enlisted originally in the United States Air Force. Following Air Force, he actually did undergraduate in Florida, and then did his med school and residency at Emory, where he was chief resident as to be expected. And then following that, he did fellowship in Colorado at Centennial Schultz, one of the premier training grounds for regenerative medicine. And while he was there, he was instrumental in developing techniques as well as a number of publications speaking all about regenerative medicine. And currently, he is the founder and medical director for Interventional Orthopedics of Atlanta, where they do phenomenal things there, treating a spectrum. Originally, I was going to say from the neck all the way down to the feet, but he's also taking care of people with their jaws and other things along those lines that we're going to talk about a little bit in depth and detail. He has numerous accolades and awards where he's been awarded 40 under 40. He's not only an IOF member, which we'll talk a little bit about that, he's an instructor for regenerative medicine, and is just really not only incredibly accomplished, but one of the most down-to-earth docs for all the different things that he's been able to do. And on top of that, right now, he's also dealing with a newborn baby and managing all of this with aplomb and no challenges whatsoever. Dr. Christopher Williams, it's a pleasure to have you join us today. Thank you so much for being here with us.
Thank you so much, Dr. Landrum. That's a stellar introduction. I really appreciate it. That is very, very, well appreciated. I thank you for the high remarks. And I'm trying to juggle. Hopefully I won't fall asleep here from the sleep deprivation.
We can see the baby seats in the back, and we know that you are managing it all. Well, let me be clear, with obviously you helping your wife. Let me not get in trouble when you get home. Yes. We don't want any problems or issues on that end.
No, we don't.
Okay. So let's get right into it and get after it. And I know that, you are one of the premier people to kind of talk about this. So we hear this term that's called interventional orthopedics. And I think that's confusing for those people who are not necessarily really entrenched in that, because I think orthopedics, they automatically think surgery. Can you give us some context of what exactly does that mean? Would you explain that in your own words so that the layperson can be able to understand what exactly that definition would happen to be?
Yeah, that's a great question. I feel like the medical community and the medical media has done a poor job with kind of categorizing the different elements and subfields within the spectrum of orthopedics, right? So, of course, we have orthopedics as a whole, which just means, attending to somebody's musculoskeletal issues. Then within that field, we have the field of surgical orthopedics, and then from there we have non-surgical orthopedics, and within that subfield of non-surgical orthopedics, we have things like sports medicine or even interventional pain management. And the field of interventional orthopedics, the primary goal is to form a bridge between the two, so there's not so much of a segregation. So that way, there's a spectrum of treatment, and so we really try to walk a fine line of doing minimally invasive treatments that can prevent fully on surgical treatments, but also in any case or situation that presents itself, try to do as many non-operative treatments as possible. So, we know that everybody is not a non-operative candidate and everybody is definitely not a surgical candidate, but we try to walk a fine line and always, try to have the goal of function and functional improvement as the premise as well. So it's just the same. I always give the analogy as cardiology and having the spectrum of, cardiothoracic surgery for patients that need their chest cracked open after they have a large myocardial infarction, or somebody has cancer and they have to have well. So, there's a lot of
You gotcha. Okay. I think we might have lost your video for just a second there, Dr. Williams. But we have your audio. So you were saying.
Okay. So just really trying to bridge that spectrum. I'm not sure if the video will pop back in here. Hopefully it will. But trying to bridge that spectrum of care from the non-operative to the interventional or surgical side of things as fine as possible.
Understood. And so how did you originally get connected to interventional orthopedics, and what was it that really drew you to it?
Really enjoyed doing things with my hands. And so when I was thinking while in medical school, what do I want to do? Do I want to do surgery or do not do surgery? The personality type really didn't fit mine. I hate to try to pigeonhole people, but overall, the general personality type of a surgeon was not really that of mine. I'm a very laid back person as well, but I wanted to find opportunities to treat patients for musculoskeletal injuries because I was very into health, nutrition, and working out and things like that. But, I wanted to provide other options other than the traditional care, which was really, if you're not a surgeon, what you traditionally had kind of been pigeonholed with is, prescribing physical therapy, prescribing anti-inflammatory medications, and doing steroid injections. And so as I was going through training, I heard about the field of regenerative medicine for orthopedics and kind of the startings of interventional orthopedics. And that really, piqued my interest with things like PRP that were started to branch out and really getting patients good outcomes without having to do things that may be detrimental to them, such as cortisone injections, but providing long-term relief instead of the traditional revolving door of pain management that we sometimes have seen and experienced in the past.
So from a patient's perspective, how does this differ, do you think, from traditional orthopedics when you use the context of interventional orthopedics? What would they experience differently?
It varies.
Hey, Chris, I think we're losing your audio again. It's kind of jumping in and out a little bit.
Huh.
There we go. We can hear the huh.
Okay, there we go.
All right, go ahead.
Sorry about that. I'm not sure what's going on there. But so from my perspective in my practice, and it varies by practice, of course, but traditional versus interventional orthopedics, I'm a physiatrist by training, and my goal is always functional driven. So what are your goals? What are your expectations, and how reasonable are they, and can I help you attain those? And so when I see somebody for the first time, I'm not just looking at traditionally when you see orthopedics, you come in with knee pain, they may spend 15-20 minutes with you at most, come in, check out your knee, and do an x-ray. Then you say you're surgical or non-surgical. If you're non-surgical, try some therapy. Here's an injection or some medication, send you on your way. I'm going to spend about an hour with you to try to figure out why you have knee pain. I'm going to look at your whole kinetic chain of that knee to see how it's influencing your pain, looking at your hip, your ankle, your lower back, going over your images with you. So that way you're as well informed as a patient as I am. So because at the end of the day, being a doctor, the Latin root word for doctor means to teach. So if we're not providing our patients, if they're not leaving more full with information than when they walked in the door, we're not doing a good job. So I always make sure that I'm educating patients, keeping function as the premise, and also expectations. And then from there, we can talk about, well, how do we get you to your goal? And so that may mean that we work together with weight loss. We may look at anti-inflammatory supplements. We may look at dietary modifications, or we may do injections as well. But the goal would be, how can we do this in a minimum? We can avoid surgery if at all possible.
Understood. And we can tell your level of academic rigor, because as soon as we heard kinetic chain, we're like, okay,
I'm
we're
sorry.
in for it now. We're like, all right, we got it.
I'm
So
sorry. I'm speaking a little bit medical jargon, but
I know it just pours out of you. I
I'm
get it.
sorry.
It's okay. I'll make sure that we bring you back down. That's all right. Okay, so I got a question for you. So today's topic, we're talking about subchondroplasty and those type of nuanced pieces that we're going to talk about with some depth and detail. But prior to that, what we really want to have a little bit of clarity about is bone marrow lesions and how and what those are, because I'm pretty sure most people are like, I have a lesion in my bone. Is that a good thing, a bad thing? Is that there all the time?
Is it
So
cancer?
can you give us a little bit of insight about what the heck is a bone marrow lesion and why should we care?
Yeah, great question. Definitely some points for clarification. So at the most basic level, a bone marrow lesion is just swelling within the bone. The 9 times out of 10, we see these in patients that have arthritis. Sometimes we can see them in folks that have had traumas to the knee. So if you bump your knee hard enough, the bones smack together and then they get swollen, just like anything else. I always talk to my patients about it like if you were clapping your hands for 8 hours for the day, at the end of the day, your hands would be swollen and red. So that's usually what happens in the realm of patients that have arthritis. They have thinning and loss of the cartilage. The meniscus is usually kind of trashed a little bit also. And so the bones are much closer together than they normally are. So when you're constantly walking, they constantly have micro impaction or friction of the bones and you get swelling in the bone. And with that swelling is inflammation. And with inflammation, we have pain.
Are all bone marrow lesions symptomatic? Meaning, does everyone always feel pain if you have a lesion? One. And two, how do you know if you have a lesion? Can you feel it in your leg? How do you know whether you have a lesion or not?
Very, very good. No, not all bone marrow lesions are painful. But some of them are. And usually the ones that go hand in hand with arthritis tend to be a part of the painful spectrum of arthritis. So they're usually not the only component of a patient's pain that has arthritis. Usually there's, inflammation within the joint, there's damage to the ligaments, there's, damage to the cartilage and into the bone and all of these things together. But when patients just have a lesion of the bone or just swelling of the bone, it may not be painful. Sometimes after someone has trauma, they have an impaction of the bone and they don't necessarily have any pain there. And usually those go away on their own. Sometimes they can be painful if they have a trauma and it's a small fracture there as well. So there's a little break in the bone that's kind of a micro fracture of the bone. And there's a lot of swelling around that also as well. And so most of the time when you do have symptomatic or painful bone marrow lesions, that may be tender to touch. Sometimes it can just be achy or throbby like a toothache, and it aches at nighttime, or you just kind of not even, walking or putting weight on the joint. You can still just be sitting down and just kind of aching of that joint or your knee or wherever you have that problem at. Usually that's kind of that inflammation causing that pain. So that's kind of some of the telltale signs and symptoms of having symptomatic bone marrow lesions. It may hurt to push on it, or it just may ache like a toothache.
All right. Thank you. So, question for you that I'm hoping you can be able to kind of clear things up so we can be able to kind of understand it like this. And that is, why doesn't orthopedic surgeons talk too much about bone marrow lesions? I know that I've mentioned this to patients and they're like, my surgeon never talked to me about a bone marrow lesion. How is this that important? Can you give us context for that, please?
Yeah, that's a great question. I think that the conversations are now being had. I think at the most simplest form of it, conversations with surgeons is usually driven from a surgical perspective, right? And so traditionally, this wasn't a treatment that a surgeon usually went after because there was really no approved treatment from an insurance standpoint. But now, there's subchondroplasty when you're injecting calcium products that can be approved. So now I think some of the conversations are being had. But previously, a surgeon really just kind of thinks of that as either a spectrum of the trauma. So do we fix the trauma, meaning that if you have a broken bone, if I'm not going to do anything.
Audio's in and out.
Our audio went out. Are we?
There we go. All right.
Sorry
If you're
about
not
that.
going to do anything as a surgeon, what was that again?
Yeah, if you're not going to do anything, it's probably not going to be on your radar, meaning that even if you have the swelling in the bone, if I'm not going to put a pin in, if you have a fracture, put some type of fixation device in, or if you have a bad or advanced arthritis, if I'm not replacing the joint, then do the do the non-operative conservative stuff, your therapy, your medications, because that's just a part of the problem. It's not, there's nothing that I can do to fix that. But that may be some more surgeons starting to have those conversations, because now there's a surgical code that you can actually bill for subchondroplasty when you're injecting the calcium products or demineralized bone products into the bone. So maybe it may evolve in the future.
Okay, so now we've broken out the term that we're really looking to kind of get into and understand, and that's subchondroplasty, which is a fancy long word for those people who are not into kind of the arcane uh, aspects of medicalese, if you would. So, can you talk to us about what is subchondroplasty and how does it treat maybe these bone marrow lesions? And really, is it something that's just an incidental finding? Is this the major issue? Or maybe it's more arthritis and the loss of cartilage, where you hear the same phrase over and over again that you're bone on bone, and that's the major thing. How frequently are we missing maybe the boat and it's more bone marrow lesion than bone on bone? That's a lot to kind of unpack, but perhaps you can kind of give us some insight about it.
Yeah, let's bite it off and just break it down piece by piece. So the first thing, the term, right? So let's get to the root word, or break down the word into small little sub bites. Sub meaning under. So we're just injecting, or plasty, injecting something under something. So chondral, so subchondral meaning under the surface of the bone, and plasty meaning we're putting something in there. So that putting something in there can be whatever it is. It can be, you can put more bone in there, you can put calcium or different elements in there, you can put bone marrow in there as well. So the spectrum is pretty broad. So the term subchondroplasty means that we're injecting something into the bone under the cartilage. The premise or thought behind that is that excuse me, we know that there's an interface between the cartilage and the bone underneath, right? So the cartilage itself doesn't have blood flow. Really, that's why the cartilage that we're born with is usually what we die with. It doesn't repair itself, it doesn't regenerate. So, it really gets its nutrients from the bone underneath and also from the synovial tissue within the joint. So there's this constant interplay between the cartilage and the bone underneath. When there's a trauma to the bone, to the cartilage, the bone then reacts to that as well. And when there's damage to the bone, it affects the cartilage as well. That's why people that have had a trauma to the knee, like my mom, for instance, she was in a car accident, banged her knee up against the dashboard, and now she has bad arthritis in that knee. And so it's no coincidence that happened, because when she sustained that traumatic impact, it damaged the bone, and then that in turn led to a cascade of events that led to the cartilage degenerating, because there's this interplay relationship between the two. Are we missing the forest for the trees by just focusing on the cartilage? I think that's been the dogma for years, because initially we didn't think arthritis was an inflammatory problem. We thought it was a pure mechanical issue. And so there's a spectrum of inflammatory arthritis that we try to, tuck away as gout or rheumatoid arthritis or lupus. We didn't think that primary arthritis, which is about 90 to 95% of arthritis, had any inflammatory component. But now the science has really evolved, and we know that that's not the case, that arthritis or primary arthritis or old age arthritis is primarily an inflammatory problem. So, Why is it an inflammatory problem? That's because that there is a interplay between the synovial tissue that really supplies the cartilage with nutrients and communicates with the cartilage, but also the bone that supplies the cartilage as well has a interplay an effect on that inflammatory and inflammation process as well.
Okay, so when we talk about subchondroplasty, there's a whole host of different injectates that can be placed there, or things that we can inject into the areas you mentioned before. And without pigeonholing, surgery does this, interventional orthopedics does this. As a norm, there are certain things that are traditionally done by surgery, and there might be other things that are done by regenerative medicine specialists. Can you give us some insight in terms of what might be injected on the one hand and what benefits might it provide versus the injectate that you might get from a regenerative medicine, and how is that going to benefit the patient?
Yeah, thank you. That's a good question. So, the underlying problem, yes, I mentioned that the bone marrow lesions or swelling in the bone is primarily edema or swelling, but also the bone itself, the architecture of the bone is brittle. So it's if you think about it, like if you had the Eiffel Tower, right? And if the Eiffel Tower was made out of ice and you kept it in the freezer, that's how normal bone is, kind of interwoven, connected together, very strong. But if you set the Eiffel Tower out that was made of an ice sculpture and just let it start to melt, it will become brittle, right? So the parts of the bone where there's bone marrow lesions, it's not very strong bone as well. So the thought process is that bone is made out of calcium and phosphate. So if you inject calcium and phosphate into the bone, then ideally we can help it to turn back into normal bone, and also decrease the pain and decrease the lesions in the bone. So that traditionally, there are things like calcium phosphate. There's also something called demineralized bone matrix, where you take bone from other sources and kind of take some of the minerals out of it, whether that be from cadavers or different animals, and then you can inject that into the bone with the same premise of we're trying to help this stimulate normal bone regrowth so that the architecture of the bone returns to normal. But then there's also orthobiological, another big word, biological options as well, that come from the own patient's body, such as bone marrow, stem cells, or even platelet-rich plasma that you can inject into the bone, try in the same vein of trying to get the same result, which is a normal return of the bone's architecture. But also remember that it's an inflammatory process, so decreasing that inflammation, which then ideally can decrease the pain.
Okay, so can you talk a little bit about what does the patient feel, both intraoperatively as well as postoperatively? Because how I would kind of voice for the patient is, wait a minute, you're injecting my bone? Like, what exactly does that mean? And how are you going to do that? And I'm going to tolerate that. So maybe you can give us some insight about that.
Yeah, I'm not anybody's friend during that procedure. It sucks. It hurts. It's very painful. Initially when I started doing those types of injections into the bone, I used to do them awake, or attempt to do them awake, and it did not go well. It's very painful, and I speak from personal experience. I've had my bone injected for a problem I had in my shoulder, so I've had it done twice. So I can speak personally of having it done awake. But everybody that I've tried to inject awake, it definitely doesn't go well. It's very painful. It's extremely uncomfortable, type of procedure, because you're pressurizing bone, and bone does not do well with pressure because it's a solid material, and that causes a lot of pain. So I usually provide a substantial amount of sedation through an IV, so that way the patient is comfortable and doesn't have nightmares about me in the procedure. So post-procedure, it's not that bad, to be honest with you. It doesn't necessarily hurt more than our normal types of procedures that we do. We do take some additional precautions depending on what area we may inject into the bone at, meaning that we may make you non-weight bearing or partial weight bearing for a couple of days. But usually if it's just for a knee or a shoulder, we don't modify your weight bearing status. But we do make sure that we're very conscious about watching the injection site for any bleeding or infection, as well, because those are rare side effects, but we have to be vigilant to make sure we're not going to miss anything.
Okay, so you are giving us all kinds of tidbits, and I can tell that you actually dropped us a few nuggets about body parts and what might be able to be done. But we're going to save that, just like we had a cliffhanger. We're going to take a little bit of a break, and then we're going to come back and ask, so what body parts can really be treated after this quick message?
I'm Dr. Orlando Landrum, a Harvard and Cornell trained MD who specializes in interventional pain, regenerative medicine, and neuromodulation techniques. I've helped thousands of patients be able to get their lives back and eliminate their pain.
So again, today, we're joined by Dr. Chris Williams, who is a phenomenal authority in the field of regenerative medicine. And we're talking about subchondroplasty to be able to treat a number of different processes, but specifically bone marrow lesions and how that can be able to provide benefit. And right now, what we're going to talk about is what are some of the different body parts that can be utilized for this treatment, and how long has something like this been around? Because I'm sure people are like, well, I don't necessarily want you experimenting on me. This has only been out for a year or two. Maybe we have some other people get this done and we see some studies. But I think Dr. Williams is going to be able to help really clarify that and give an explanation of the benefit and how long-standing it's been. Dr. Williams, again, thank you for joining us.
Thanks a lot.
So you can tell us a little bit about what body parts might be able to be used for this?
Yeah, it's pretty interesting. I think most bones in the body are almost fair game. There are a couple of things that are not fair game, and we really get into the non-fair game things when we talk about the spine. Some of that's fair game as well, but typically most people, the vast majority of bone marrow lesions or swelling in the bone tends to involve the knees and the hips, and then other areas that have damage, such.
So just to reiterate, because I think your audio is going out a little bit here and there. So the knees and hips in particular is one of the things that I think you stated, but I think you made a quick allusion to it also possibly being in the shoulder as well. Let's see if we got your audio back. Nope, not quite yet. All right. So we're hopefully going to get that audio back in the next few minutes or so. But we know that knees and hips have been done. And we also know that there have been, a historical trend for utilizing this in the past in other areas as well. Dr. Williams, can you give me some insight about whether you have that audio back yet? Let's see. No, not quite yet. So be that as it may, one of the things that we really want to kind of talk about is, so who might be some better candidates and how do you figure that out from an imaging standpoint? Let's see if maybe, over the next few minutes, we can kind of get to that. We're going to kind of do a little bit of technical eval. At the same time, we're going to kind of have you take a look at Interventional Orthopedics of Atlanta, where Dr. Williams is the founder and medical director. And we'll be back in just a sec. All right, so I think we may have audio back, so we're going to see in just a second or so whether we can get Dr. Williams back on to kind of have some of those insightful answers. Dr. Williams, can you hear us right now?
Yes, I can. Can you hear me?
We can hear you as well. Perfect.
Awesome.
So can you talk to us a little bit about, besides the areas of knee and hip, what else might be able to be done? And how long has this been around where it's had some type of utility and use?
Yeah, no problem. We can treat other areas. We commonly treat the ankles for patients that have swelling or bone marrow lesions within their ankle bones, their wrist bones, big toe, their hands or thumbs is a common area as well. The wrist, also elbows, not that much. Shoulders into the clavicle or into the humerus, the top part of the shoulder bone here, as well, is pretty common as well. So we can target a lot of areas. The lumbar spine or the back of the pelvis, where the hamstrings connect to, we can treat that also. So there's several different areas that we can treat safely. And these types, so in general, injecting into somebody's bone has been being done since the 1980s. It's been being done a long time.
I'm sorry, Dr. Williams, you said since the 1980s?
That's correct.
Is that right? Back when people were doing like popping, locking, and breakdancing and stuff, the 1980s has been that long?
Absolutely. Maybe they locked on to some bone marrow lesions and they had to get them treated.
And so where was one of that first incidences in 1980s? Was it done here in the States or someplace else?
Yeah, not to my knowledge. The first the earliest injections that I know of was done by a French physician, orthopedic surgeon by the name of Philippe Hernegal. And he was doing primarily a lot of this work in the hips for necrosis of the bone, which is a type of bone marrow lesion that's a little bit more advanced where the bone starts to die off. And so he was a surgeon, but he wanted to look at non-operative treatments. He started injecting these lesions with bone marrow back in the 1980s and has been doing it since then, and is one of the pioneering forefathers of this treatment. And we just kind of extrapolated from that, and really these types of injections has really taken off, I would say, probably over the past 7 years or so. But we've been doing it now consistently since then, but it's more mainstream now, for sure. But since the 1980s is when we kind of started it.
What are some of the major benefits of using bone marrow as opposed to using, a calcium phosphate? How does that differentiate, and what's the value to the patient?
Yeah, so in short, there's been no head-to-head studies to show that one is more superior than the other. So, in theory, though, the thought process is that you probably want to inject something in the bone that is very similar in composition as the bone itself, or is close to composition of the bone. And bone marrow is unique because it's what the body normally uses to repair bone, right? So if I break my leg, hopefully I don't, but if I break my leg, 90% of the time, we can put a cast on somebody's broken leg, and the bone in that area, the bone marrow then produces new bone and heals that fracture, right? That broken bone. So the thought process is that we're providing a more complete type of treatment when we inject bone marrow, because of the stem cells and the other components within that bone marrow can also address more comprehensively the problems that exist within that bone. Because we know that when we have arthritis and things like that and bone marrow lesions, that there is a lack of stem cells in that bone, which is likely contributing to the problems or pathology of that bone. Calcium phosphate may be helpful as well. The literature is kind of all over the place. There are some studies that show that it's not beneficial. There's some studies show that it is. The verdict is still out, but we know that there are several studies, not several, I should say, at least 3 studies that show that bone marrow injected into the bone is significantly beneficial. And for arthritis in particular, it can be just as effective as a knee replacement, and long-term outcomes up to 15 years, but also in terms of necrosis of the bone, which we're not really talking about, but it can be a long-term effective treatment lasting upwards of 30 years of benefit. So, there's a little bit more data for bone marrow than things like calcium phosphate or some of the newer, cooler things that are kind of out there that are covered by insurance. So they're getting a little bit more of the spotlight right now.
Okay. So as an aside, we have a question from one of our audience members, and we know that this is a little nuanced because you need to know a little bit more from the patient and all these other type of dynamics about what's the context and how does the patient experience it, and also probably do an examination as well as some imaging and such. But be that as it may, one of the things that they have is this possibly helpful for severely torn meniscus as well as thin cartilage that has little cartilage that's left, is how I would interpret that. And I know that's a difficult question to be able to answer, but plus or minus to the best of your ability, any way that you can kind of give us some insight about whether this is feasible or not.
So speaking in general and not specifically to the patient's specific clinical scenario, because you shouldn't Instagram or Facebook treat patients, I should say. But in general, so when you have tearing of the meniscus that is in the setting of arthritis, we call that kind of degenerative tearing of the meniscus. And yes, there have been studies that support and show that not only does bone marrow help with those problems, but also something as simple as PRP has been found to be effective for decreasing pain and improving functional outcomes, making you feel better and be able to do things that you like to do, or injecting PRP into the bone, or what we call platelet-rich plasma, which is just from a simple blood draw, which can be very effective. Usually, my algorithm is that for mild to moderate arthritis with some degenerative tearing of the meniscus, I usually will look more so into doing a PRP injection. If it's more advanced arthritis, then I usually go down the direction of doing more of a stem cell treatment. But I will say there have been no head-to-head studies comparing PRP and bone marrow into the bone and seeing which one is more effective. We don't know yet, so a lot of that is based off assumption as well.
Okay. So the next question is not putting you in an Instagram, Facebook, or any other social media like quandary or like pseudo gray area. And I think it's a little bit more of an easier chip shot. And so the question is maybe I missed this, is a bone marrow that's injected from the patient or from a donor?
Oh, that's a great question. That's a very good point of clarity. It is only from the person, because if we're talking in the United States, it's actually not FDA compliant to inject anybody else's bone marrow into anyone else except for the treatment of specific bone cancers, like, or blood cancers, I should say, leukemia, lymphoma, and now also for doing some things like stem cell transplants for sickle cell disease as well. But for arthritis, etc., it's not, that's not kosher. It's not good to do that. It's not FDA compliant, and nobody should be injecting anyone else's cells into someone else unless it has those indications for a blood cancer, sickle cell, etc.
Okay. So let's kind of jump back to that bigger topic of interventional orthopedics and regenerative medicine. What are some of the greatest or most common myths about interventional orthopedics, and can you debunk them?
Is voodoo medicine. Voodoo, there's no research, it's quackery. Yeah, I think the biggest one is that there's the thing that is unfortunately purported by a lot of traditional doctors and also in the media, is that, there's no research behind it. I think that we have not done a good job in the medical field with debunking that. But there is a decent amount of studies, in terms of just PRP, platelet-rich plasma. There's over 70 level 1, randomized research trials, which is the highest level of medical research, to show whether it's efficacious for treating orthopedic conditions. And when we talk about bone marrow, there's definitely some randomized trials that show that it's as effective as knee replacement as well. So, the data is there. The insurance has not followed suit. That's a very political issue. I'm not a politician. But, when we look at things like meniscectomy, or the most common arthroscopic, which is when they put a scope in your knee, surgery that's done by orthopedic surgeon is when they cut out the torn meniscus. It's about 550 to 600,000 of those surgeries done in the United States every year, and it's proven out with research studies to show that it's no more effective than physical therapy, and it also leads to a faster progression of arthritis. So it's not really, the issue of is there research behind it or not. I think it's a lack of education. We do a poor job that after we finish medical school with staying on top of the current and latest and greatest research that's in our fields, and we just are continually eating off the same stale bread that existed from 10, 15, 20 years ago whenever we finished our medical training. But medicine evolves, and there's a lot of things that come out every day. I get about 50 articles emailed to me through PubMed every day, and when I wake up in the morning, when I'm doing my morning rituals, I scroll through these articles and just read the titles and try to find the ones that are relevant. So we have to do a better job as providers and medical doctors and, teachers to stay abreast on what's going on in the field of medicine, and particularly in orthopedics. So I'd say the biggest thing is that there's no research and it doesn't work, which is definitely not true. And I would say also, insurance is probably the next one, and I don't know if we're going to get into insurance coverage or not, but I can speak on that a little bit also.
Okay. So to that end, with the PubMed articles and other things that you have and the teaching that you have, what are you most curious about right now from a medicine and orthopedic standpoint that you think is really an interesting development or seems to be having some degree of legs?
To be honest with you, I think the thing that there's two different aspects, right? So there's kind of the mountaintop or holy grail, then there's the reality. So within the reality space, what's available now, I think that has the most promise is really subchondroplasty and subchondral injections, based on the recent data that's come out over the past year showing that it can be just as effective for a long-term treatment option as a knee replacement. That's phenomenal, because it has significantly less cost, significantly less side effects, and significantly less risks associated with it. So, if we can, replicate that data on a broader scale and make these treatments more widely available, that's phenomenal, from not only the United States, but what we can do abroad in areas that are lesser developed. So that's kind of, ground level, but holy grail things that I get excited about is, of course, synthetic cartilage or synthetic meniscus type of things. And how do we really develop those things? CRISPR technology. How do we edit genes so that we're less susceptible to these types of degenerative conditions over time? And so I think those things are down the pipeline. Further along, cartilage engineering has been something that's been trying to have been in the pipeline for quite some time. Meniscus engineering, it just hasn't really panned out as much as we wanted to, because it's a difficult feat. Everybody's bone structure is different, so it's hard to 3D print something, but also allow it to not only look like cartilage, but also to function like cartilage within the body without the body rejecting it. So we haven't reached there yet.
Okay. So kind of use a Tim Ferriss kind of question. If you could have a billboard with anything on it, what would it be?
Does it have to be related to orthopedics?
I gave you the disclaimer of anything on it.
There we go. I think probably, I've always been a fan of the quote of "be the change you want to, see in the world, be the change," etc. Kind of from my mind popularized by, Gandhi, but it's been used and regurgitated several times thereover as well. So, health is wealth is probably, I would have that as a little cliff notes at the bottom. Because, that's something that we find out later in life as we or if we're fortunate later in life. But some people that aren't as fortunate, like the late great Steve Jobs, said there's no amount of money that he could pay somebody to take on his disease. So, we tend to get into a habit of chasing, things that aren't very important, and forget that, a lot of the times we sacrifice or to our detriment the things that is most precious to us, which is time and health.
Dr. Williams, as we start kind of wrapping up here, quick question, because I want to make sure I don't miss this. Where can people find you? How do they figure out, you know what? I really like this guy. He's super on top of it. He understands and explains it the way that I get it. Where can they be able to find out more about you?
Yeah, so I'm on IG, so Instagram. You can find me at ATL Stem Cell Doc. Disclaimer, you may see some pictures of what I think are my cute kids. You may think they're Rugrats. I do post some music pictures also, and videos. I'm a big music aficionado, whether that be everything from hip hop to Afro beats to classic rock as well. But ATL Stem Cell Doc, the website as well, www.ioaregenerative.com, which stands for Interventional Orthopedics of Atlanta. And that actually serves as a direct feed. My Instagram actually feeds directly into the website as well. So you can get me both ways. And also from the website, it has my links for, Instagram and Facebook, etc. on there also. And I'm on, Instagram a couple times a day, answering questions as well. So I'm always available.
So, not to make this a major plug about you, but I really do appreciate you coming in. So where are you located in the country?
Yeah, so the clinic is in the Buckhead area of Atlanta. So if you're not familiar with Atlanta, it's kind of the business district of Atlanta. And it's thriving, very busy area. It's about 20 minutes from the airport as well. We have two hotels located directly across from the clinic. I'm in a medical office building as well, where there's just medical professionals in the building. You're not going to see a hoagie shop next to me or a pizza place. So that's where I'm located at. Not to knock anybody that's on the strip. We all got to get it however we can get it. So.
Okay, two more questions. If you could step into my shoes and ask yourself anything, what would you have asked? What did I miss asking you about interventional orthopedics or about subchondroplasty that you feel like would be really beneficial for our audience?
Yeah, I would probably say, are these procedures covered by insurance? And if not, how much do they cost? And I'm always like to talk about side effects and what are some of the side effects or downsides of the treatment of subchondroplasty. So that's what can I answer my own questions?
I expected you to.
Okay, very good. So insurance does cover some of these things, like we talked about. Subchondroplasty in general with calcium phosphate or demineralized bone matrix is covered by insurance. When we talk about a lot of the interventional orthopedics or biological type of procedures like PRP or stem cells, most insurance companies don't cover them unless you have a health share plan, like with Samaritan Ministries or one of those types of health share networks. They do cover most of our procedures. Or if you're the company I work with is with Regenix, and they have corporate clients, so self-insured employers that they work with, and there's over about 6.5 million employees and their family members that get our procedures at no cost as well. Because when we talk about these things with employers, it really boils down to dollars and cents. And when we talk about, say, knee arthritis, they can say that, hey, do I want to pay 50 grand for a knee replacement for my employee? Or is this subchondral stuff is just as effective, and I can get away with paying, $6,000, $7,000, $8,000 and getting them back to work faster? So it's an easy sell. So it depends on your insurance plan, but traditional private insurance, your Blue Cross, your Aetnas, most of the time they don't cover these types of procedures. And side effects, it's a very safe procedure. The things that I've seen, I've never seen anybody have an infection. I've seen in the literature that there was one infection after a subchondral injection of calcium phosphate, if I'm not mistaken, or maybe demineralized bone matrix, but it was a case report where somebody had an infection after that, but I've never personally experienced an infection. The most common thing is pain, and probably 3 times I've had patients have some bleeding from the site that usually stops within about 24 hours. So nothing that was long-term, nothing that was significant. I've seen some remarkable results. People get back to doing some significant activities. I've treated, patients, and they are able to do things they love to do, which is the goal, right?
Thank you for summarizing that. Really appreciate it. All right. So last question. If you can look back on yourself in 3 years, what has to have happened both personally as well as professionally for you to feel like there has been some degree of success?
Yes. So I would say personally and professionally. So personally, I hope to have a couple more gray hairs and be a little bit wiser and sleeping a little bit better. And have evolved into a more patient father and spouse. That's kind of, all jokes aside, but personally just continue to evolve, and be more well versed in terms of life and experiences and people, more well traveled, as well as seeing and learning some new things that I have not experienced. I would have hoped that I would have impacted the lives of several of my patients by that point in time, that I have partnered or evolved my practice to, that I have at least some other professionals. I have a physiotherapist that I work with right now in-house, but at least some other medical professionals that I either work with in-house or partnership with, as well as my practice continues to evolve. I'm also involved with, I do real estate and some other stuff. So I hopefully will have, ownership in at least, 10 to 20 properties within 3 years from now, just trying to build some generational wealth for myself and my loved ones. And also giving back to the community that I come from, and making it a more desirable option for, minorities and people that come from disadvantaged backgrounds to know that you can do things and be successful other than from playing sports or, making music such as rap. So that's kind of some of the goals that I would say.
All right. Dr. Williams, it's always a pleasure to be able to talk to you. It's been even more of a pleasure to be able to have you on this live stream where people can be able to get insight from you and the things that you've done and how you help really be able to kind of further this technique in a lot of different ways from a regenerative medicine standpoint, and hopefully be able to impact people's lives. We'd love to have you back when you have time, which I know is limited, both with work as well as with family responsibilities, to talk about regenerative medicine in the future if you're so inclined. Really would appreciate it. And again, we thank you so much for joining us.
It's my pleasure. I love to come back. We've been trying to get this on the books now, I think, for maybe 8 months or so. But it's important, man, and I really appreciate you, because you can, speak and have this platform and have anybody on here that you want to. So I appreciate you reaching out and extending the opportunity for me. So it's always a pleasure, as well. It's always a pleasure to talk with you as well, man. So definitely be safe, and be prosperous.
You as well, and I'll tell you, the wait was well worth it. Thank you so
sir.
much.
Thank you.